Welcome back to the Deep Dive. If you're an emergency department practitioner working anywhere in the UK major trauma network, and we know how demanding that is, this deep dive is, well, it's mission critical for you.
It really is.
We are talking about silver trauma. It's a term that really it defines the new reality of your workload, and it demands that we fundamentally rewrite the book on trauma assessment.
We absolutely have to. The stakes, they just couldn't be higher. We're talking about significant injury in patients aged 65 and over.
And this isn't some niche category, is it?
Not at all. This group now makes up the majority of major trauma cases we see across UK trusts.
And that's the core challenge, the thing you face on every single shift. The traditional trauma assessment model, the one we all learn by heart, is failing this population.
It is.
Why? Well, because their physiological reserves are just so diminished. They have complex comorbidities. They're often on polypharmacy. All of this, it just combines to blunt the typical, the screaming signs of a severe injury.
And the outcome of that is, frankly, unacceptable. It leads to systemic under-triage, to delayed diagnosis, and disproportionately high morbidity and mortality.
So our mission today is to unpack this necessary paradigm shift.
We have to stop just running an injury-centric checklist. We need to move firmly into a patient-centric, holistic model, one that integrates geriatric assessment from the very first minute they arrive.
Okay, so let's start with the definition. What exactly are we classing as silver trauma?
So the baseline is significant injury in patients 65 and older. But what's interesting is that local guidelines are now recognizing that age alone isn't really enough.
It's too blunt an instrument.
Exactly. So they often combine it with a measure of vulnerability, for instance, being 65 or older with a clinical frailty score, a CFS of 5 or more.
And the sheer volume here is just staggering. You said they're the majority, and the data, it really backs that up. They're the fastest growing demographic in the entire major trauma network.
It's a real shock fact for many trusts. In some places, 70% of major trauma activations are for patients aged 70 or over.
Wow. So this isn't a future problem. This is right now.
This is your shift tonight, and it's built on what we call the mechanism trap.
The mechanism trap? What do you mean by that?
Well, when we hear major trauma, our minds instinctively flash to, high-speed car crashes.
Yeah, RTCs.
But for the silver trauma group, the low-energy fall, a simple stumble from standing height, less than 2 meters, that is the most common mechanism leading to major injury.
So an injury severity score over 15.
Precisely. It's a fundamental reversal of our training. A shove off a curb is now causing more death and disability in this group than the high-velocity collisions.
So if you see a 75-year-old who's had a simple fall, you have to treat it with the same suspicion you would a pedestrian hit by a car.
That's the mindset shift. And it ties directly into the concept of frailty. Chronological age, well, it's easy to measure, but it's a really poor predictor of outcome.
Right.
Frailty, which we measure with the CFS, reflects the patient's intrinsic vulnerability. And it is a far, far superior predictor of how they'll do post-injury. It's what you need to focus on.
Which leads us straight to the clinical warning signs, or the lack of them.
Yeah.
The atypical presentation.
Because of age-related changes and common medications, things like beta blockers, shock is almost always masked.
So you could have a patient with a catastrophic pelvic fracture bleeding out, but their heart rate is 75.
Exactly. And their blood pressure looks normal. Often the only clue you'll get isn't textbook pain. It's just, increased distress, or maybe the acute onset of delirium, or just an inability to use a limb. The vitals are lying to you.
Vitals are lying. Okay, let's dig into why they lie. What is this physiological erosion that's happening?
Well, you can think of aging as a process where functional active cells are replaced with inactive sort of interstitial cells.
Okay.
And that leads to this critical loss of functional reserve across every single organ system. They have no buffer, no wiggle room.
So let's take that 78-year-old with a femur fracture. In their cardiovascular system, what's actually different?
Well, their ventricular walls are stiffer. Their baroreceptors are desensitized. So when they start to bleed, the system that should trigger that massive sympathetic response, the tachycardia, the vasoconstriction, it's just fundamentally broken.
So that classic tachycardic response to blood loss is blunted, or it's just not there at all.
Or it's actively suppressed by their heart medication. They simply cannot increase their cardiac output to compensate.
Which is why the standard trauma triggers fail. We can't wait for a systolic of 90.
We can't. By then it's too late.
Okay, this is probably the most critical, actionable takeaway for anyone listening. You must change your thresholds. Why is a systolic blood pressure of less than 110 the new trigger point?
Because in this population, by the time they hit 100 or 90, they have completely exhausted their ability to compensate. They're moments away from crashing.
So 110 is trying to catch them in that pre-crash phase.
It is. And remember, if their baseline BP is, say, 160 over 90, then a reading of 120 over 80, which looks fine on the monitor, that represents a massive, dangerous drop for them. That is shock.
That completely reframes what normal means. So if we can't trust the monitor, what objective markers do we need right away?
You immediately shift to objective markers of what we call occult hypoperfusion.
So things we can measure in the blood.
Exactly. Lactate and base excess. You should routinely run a venous lactate. It's fast, it's easy, and a lactate greater than 2.5 should be considered a sign of hemorrhage until you can prove otherwise.
That's your trigger for aggressive action.
That's your trigger, even if the patient looks deceptively stable. And the base excess is just as important. It gives you that immediate picture of global acidosis and the extent of the shock.
So one last physiological point here that feels counterintuitive.
Mhm.
Neurological risk. Brain shrinkage or cerebral atrophy actually increases the risk.
It does. It stretches the bridging veins in the subdural space. So a very minor fall, a little knock, can cause them to tear.
Which means a higher risk of a subdural hematoma.
Yes, and because of that extra space inside the skull from the atrophy, the brain has more room to compensate for a slow bleed. So the symptoms are delayed, the warning is clear. Do not be falsely reassured by a GCS of 14 or 15. A drop in GCS is a very, very late sign.
Okay, so accepting these new, really subtle thresholds for C circulation, how does the rest of our standard CKBCDE survey have to change?
Right, let's start with A, airway, and C, spine. For the airway itself, the challenge is often mechanical. You need to be vigilant for false teeth, for simple obstructions from secretions.
Because they have weaker respiratory muscles, right? They can't clear their own throat.
Exactly. But C-spine management is where the real modifications are. We advocate for a minimal movement philosophy.
Because rigid collars are standard practice, but you're saying they're risky in this group.
They are actively harmful, they are poorly tolerated, they can cause pressure sores incredibly quickly, and they can actually increase intracranial pressure.
A disaster if you've got a subtle bleed going on.
And if the patient has kyphosis, that rigid curve in their upper back, the collar just won't fit anyway. Forcing it is dangerous.
So if you can't use a collar, what's the best practice?
You support the neck in its current comfortable position. Use soft materials, rolled up blankets, blocks. The key is just minimal movement. And remember, for anyone over 65, CT is the gold standard for C-spine clearance, not plain films.
Okay, moving to BAE for breathing. A few broken ribs, we might think of that as minor, but here it can be a disaster waiting to happen.
Absolutely. Their reduced chest wall rigidity, their decreased lung capacity. It means simple rib fractures can precipitate early respiratory failure. Tachypnoea, a respiratory rate over 20, is often your early sign of developing shock. You have to take it very, very seriously.
And oxygen targets, they need to be a bit more nuanced.
Correct. The standard major trauma target is 94 to 98%. But if you suspect severe COPD, you have to be cautious. Once you have a blood gas back, you should aim for 88 to 92% to prevent hypercapnic failure.
And finally, back to SIVA circulation. Anticoagulants. How fast do we need to act on reversal?
Immediately. You identify anticoagulant or antiplatelet use instantly. You initiate reversal protocols based on clinical suspicion alone, especially with a head injury. You do not wait for lab confirmation.
If they're on warfarin and hit their head, you just reverse them.
You reverse them, and you give tranexamic acid, TXA, unless it's contraindicated. And with fluids, you restrict crystalloids. They cause harm. You activate your massive transfusion protocol early, and you use warmed blankets and warm fluids from the start.
Okay, so we've dealt with the acute injury, but now we have to layer on the geriatric component. You're saying the assessment of delirium and frailty isn't an afterthought.
It's not. It's a mandatory cornerstone part of the initial ED assessment. Delirium, that acute cognitive impairment, is a medical emergency in this context. It's a high-risk feature.
So we need quick tools for a busy ED. The Clinical Frailty Score, the CFS, is for baseline vulnerability. But what about cognition? Why the 4AT test?
The 4AT is better than just asking who the prime minister is because it assesses attention and acute change. A patient with dementia might be disorientated at baseline. The 4AT detects a new change, or inattention, which is the hallmark of delirium. A score of 4 or more means you act now.
And that action is the PNCHME mnemonic.
PNCHME. It's a life-saving bundle. P is for pain-treated aggressively. I for infection screen for it. N for nutrition and H for hydration, get food and fluids in. C for constipation. M for medication, reconcile everything. And E for environment, get the family involved, give them their glasses and hearing aids.
It's shifting focus from just stopping the bleed to saving the brain.
That's it.
Now, what about finding those hidden bleeds? Clinical examination is unreliable. How do we look for occult trauma?
That's where the shake, rattle, rock and roll assessment comes in. It's designed for quick, reproducible screening in supine patients who might be too confused to cooperate with a full secondary survey.
Talk me through the roll. That sounds risky if they might have a spine injury.
It's done very gently, but it's critical. Axial loading falls put the spine at such high risk. A gentle log roll allows you to palpate the spine, to check the back, to erect the hips. It helps unmask those occult injuries that might be missed on the initial scan. We can't skip it.
Given this high suspicion, then, we need a really low threshold for imaging.
A very low threshold. The standard is CT scan started within 1 hour of arrival, and pre-existing renal disease should not delay a life-saving trauma CT. The benefit outweighs the risk.
And for a pan scan, the whole body CT.
It's still indicated for instability. But for silver trauma patients who aren't in shock, you can consider a modified non-contrast scan to reduce the contrast load. But, importantly, a CT head is recommended for any patient over 65 with a loss of consciousness or amnesia, or anyone on blood thinners who's had a head injury.
Okay, let's talk analgesia. This is so tightly linked to preventing delirium.
It is. The key modification is moving away from systemic opioids as your default. We mandate the use of ultrasound-guided nerve blocks. A fascia iliaca block for a hip fracture is a game changer.
And if you have to use systemic drugs.
Fentanyl is preferred initially, but you must use low starting doses and titrate extremely slowly. They're so sensitive to the side effects.
And what do we need to avoid?
NSAIDs must be used with extreme caution or avoided entirely because of the high risk of renal and GI injury. And skeletal muscle relaxants must be avoided. Their anticholinergic effects are a direct cause of delirium.
So this is rarely a single organ problem. It's a complex systems failure that needs a team approach right from the start.
It has to be. Emergency medicine cannot manage this alone. Geriatrics, specialist nursing, pharmacy, they need to be involved in the ED to help guide the care pathway.
You're talking about starting a comprehensive geriatric assessment, a CGA, in the first hour.
Yes. And that feeds into the Silver Trauma Admission Care Bundle, which starts in the ED. That means having the treatment escalation plan discussion early, doing the delirium screen and PIN CHME, doing a falls and polypharmacy review, and planning for early mobilization.
And being hypervigilant for the complications.
Delirium, VTE, infections like UTIs and pneumonia, they are all incredibly common. And just a quick warning from the source material. Avoid nursing patients with potential spinal injuries on dynamic air mattresses. The movement can destabilize the spine.
So if we pull all of this together for the practitioner listening, what is the fundamental change in mindset they need to take away from this?
The key lesson is that silver trauma is not just trauma in an older person. It's a complex geriatric syndrome that is presenting with trauma. Success hinges on 3 things: early senior involvement, strict adherence to those modified physiological thresholds, SBP less than 110, lactate over 2.5 and mandatory, structured screening for delirium and frailty right there in the ED.
So it really is about moving away from just treating a broken hip and towards treating a fragile patient who happens to have a broken hip. It's about treating patients with injuries, not just injuries on patients.
Exactly. And that leaves us with a final thought for you to consider. Given the high rates of occult intracranial bleeds and the fact that a GCS drop is such a late sign in this population, how can we start to leverage objective markers like serial lactate clearance or focused imaging to actually quantify a patient's intrinsic vulnerability? How can we use those numbers to drive earlier, definitive intervention even before they show the obvious clinical signs of crashing? That quantification of vulnerability, well, that's the future of silver trauma care.